Hello, my name is Alice Escudier. I'm a heart failure specialist nurse and I work at the Buckinghamshire Healthcare NHS Trust. I'm going to do this presentation today about managing diuretics in heart failure. Okay, so the aims of today's presentation is to cover when we need diuretics, how to manage them, when to alter doses, discussion about what is an AKI and how to respond to that, and then the possibility of when to stop diuretics. So when are diuretics required? So we know that in heart failure, both with reduced and preserved ejection fraction, fluid retention is a problem, and we do need to use diuretics to manage this. So congestion and fluid buildup are hallmarks of decompensated heart failure, and we must use diuretics to manage this and try and avoid unnecessary hospital admissions. Unfortunately, unlike other heart failure therapies, we don't have exact guidelines to dose and to treat patients with diuretics. So it's essential to understand what they're for and how to use them successfully. We know that diuretic resistance can be a big problem. Some of our patients take these medications long term and they can build up a resistance. And we know that that can be connected with a poor prognosis. Our first line choice of diuretics, according to the NICE guidelines, are loop diuretics, and they have a class 1 recommendation. So how do we dose them? So the NICE guidelines recommend starting loop diuretics at a low dose, so as low as 0.5 milligram of bumetanide or 20 milligrams of furosemide. We then up titrate doses according to patient symptoms and effectiveness of treatment. We need to be aware that big doses of diuretics can cause postural hypertension, dehydration, electrolyte imbalance, and potentially acute kidney injury. It's really important to dose diuretics appropriately. We know that too low and we won't achieve our aims of offloading fluid, and we know that too high can cause unnecessary side effects. But adequate diuresis is essential to avoid hospital admission. We find that patients who are diuretic naive may not need very big doses to get an effective diuresis. But equally, we know that those who've taken diuretics for some time may need bigger doses or additional treatments to get effective fluid offloading. So what are those additional measures? So if a loop diuretic alone is not sufficient, we can use a thiazide diuretic as well. In this situation, the patient should be under the care of the specialist team. So the drug of choice that we use in this situation is oral metolazone. We give 2.5 milligrams or 5 milligrams once or twice a week, in addition to the loop diuretic. Metolazone works on the distal convoluted tubule, and alone it's not a particularly strong diuretic, but it's very effective when it's combined with the loop. The two medications together has a sequential nephron blockade and overall a really significant diuretic effect. We know that the two medications in combination will have a greater negative impact on the kidney function than other treatments, and so careful monitoring is required. Electrolyte imbalance, specifically hyponatremia, hypomagnesia, and hypokalemia, will most likely be an issue, and so vigorous electrolyte replacement alongside metolazone treatment is most likely going to be required. In some areas, metolazone is a restricted medication on the formulary, and so it may require specialist team or consultant prescription. So we know that the reality of taking diuretics can be difficult for patients. Very often people will omit doses. I know that people coming into clinic will have intentionally not taken their morning dose of diuretic because they know that they've got to travel. They might not know where the toilet is when they come into hospital. So on those occasions, people will purposefully omit the dose, which is understandable. Generally speaking, if people have mobility issues, then they are quite fearful of taking diuretics because they might not be able to access the toilet independently at home. They might have issues with urinary urgency, and so that can be something that affects compliance. I think it's important to remind people and not just assume that they know to take diuretics early in the day. We know that taking diuretics later in the day, in the afternoon or evening, will cause nighttime disturbance and again can be a risk for reduced compliance. Depending on the pathology, the complete dry weight achievement might not be possible, and it's really important to bear this in mind. For example, something like torrential tricuspid regurgitation, we're not going to achieve a patient's dry weight in this situation. So it's essential in these situations to understand that, not push too hard to achieve a dry weight, and perhaps focus on patient comfort and quality of life, and using other forms of symptom control, for example, an opioid to help with breathlessness if necessary. Self-direction of diuretic titration can be a really useful tool. If patients are sufficiently educated and happy to do so, then we can sort of give them a bit of a guideline to work within, and they can perhaps have trigger weights that causes them to increase their dose or reduce their dose of diuretic. It's also essential that these people understand red flag symptoms and to inform their team that they are increasing a dose, so that we know what's going on and we don't get to them when they've been continually increasing their doses and causing problems. Also, switching from furosemide to bumetanide can offer more effective diuresis. That's helped to overcome the resistance issues, and bumetanide does have a better bioavailability and can be a little bit more effective. So what do we do to monitor the patient? So we know that we need to monitor renal function. The NICE guidelines advise checking blood tests 1 to 2 weeks after each dose increase, but we know that occasionally more frequent observation might be needed. This is probably a good idea in anybody with chronic kidney disease, anybody that's elderly, with other comorbidities, or taking other medications that might impact the kidney function. As previously mentioned, we know that the thiazide and loop diuretic combination will require more intensive monitoring, if only just to keep on top of the electrolyte balance. Once treatment is stable, we can drop that frequency of monitoring to at least every 6 months. Blood pressure monitoring is important. We know that diuretics can cause hypotension, and so it's important to keep on top of knowing what the blood pressure is and how that's responding to different doses of diuretic. Weight is a good objective measure of fluid offloading, so we can actually quantify how well that treatment is working. And then symptom guidance, of course. So is the patient feeling better? Things like orthopnea, postural nocturnal dyspnea, edema, and shortness of breath will all guide us on whether we're achieving what we need to with the diuresis. So acute kidney injury. We know that diuretics will impair kidney function, but it's something that we need to tolerate to a degree to allow the treatment to be effective. So the NICE guidelines tell us that if we have a creatinine increase over 20%, or EGFR reduction over 15%, then we should tolerate that and remeasure within 2 weeks just to see how that's going. If we see a creatinine increase between 30 to 50% or EGFR drop below 30, we need to promptly review the patient. And if we see a creatinine increase beyond 50% with a low GFR, we need to take more urgent action. So rapidly assess the volume status. Can we reduce the diuretics? Look at other renal measures, review other medications, and refer to specialist services if appropriate. So those guidelines are useful in sort of telling us what we can tolerate, and then what we should act upon quickly. So there's some general points to remember with the things that we've already covered. It's important to make sure that a proper heart failure diagnosis has been made and the patient's had a relatively recent echo. We find often that people can be labelled as heart failure without proper investigations, such as an echo. So we can dig back through the history, make sure that everything is up to date, and according to what we've seen on the echo, the appropriate prognostic treatments are given. Obviously, if the patient's on the correct prognostic medications, then their disease is better supported, and perhaps the need for diuretics might be less. Avoiding unnecessary dose reductions or complete cessation of medications by tolerating those small changes in the renal function will ultimately lead to a reduction in cardiovascular mortality and a reduction in progression of disease. So it's really important that we hang on in there, allow the renal function to dip and then improve. So that tolerance of up to 30% deterioration is okay. Offloading fluid might actually improve the kidney function if we can relieve renal congestion. So another reason to get the treatment on board and allow those initial changes to happen. If there is a limited response to diuresis, it might be that we are having some resistance, and we can consider an alternative of furosemide changing to bumetanide or vice versa. But we do know that bumetanide has this increased bioavailability, which might be more effective. And as we said, renal congestion is very likely in heart failure patients, especially when they're overloaded. So the ongoing volume overload, if we don't give those diuretics at the right dose, is going to worsen the situation. So we're going to use a case study here just to illustrate some of our points. So this case is of Mrs. Smith, an 89-year-old lady with heart failure with preserved ejection fraction. Other comorbidities include type 2 diabetes, AF, osteoporosis, arthritis, and hypertension. So she's been seen by her primary care provider, who have referred her to a heart failure specialist team because she's had increasing peripheral edema and worsening shortness of breath. She was previously taking 20 milligrams of furosemide once a day. The GP's increased that to 40 milligrams once a day, but there's been a reduction in the kidney function, and primary care were looking for some further advice regarding that. As we can see, Mrs. Smith is also, as well as the furosemide, she's also taking ramipril, amlodipine, metformin, and some painkillers. So we can see there that there's been a reduction in the renal function. The creatinine's risen from 87 to 100, and the eGFR's dropped from 57 to 49. So what can we do? So in this situation, we must offload Mrs. Smith. We do need to increase those diuretics. We need to achieve that symptom relief. And as we said earlier, we need to tolerate that change in renal function. The renal function often worsens due to congestion, and the diuresis will relieve this. She perhaps might be resistant to the furosemide, having taken it for some time, so we could change to bumetanide, improve the bioavailability, and improve the effect. We also need to be aware that Mrs. Smith is elderly and she has a degree of chronic kidney disease, so she may well need a higher dose of diuretic to get the same effect. We also need to make sure that Mrs. Smith is on optimal heart failure treatment. So the STRONG-HF trial demonstrated how important it is that patients are on sort of optimal guideline-directed heart failure therapy, and once that's achieved, we should see a reduced need for diuretics. So in this situation, we might be able to add in an SGLT2 inhibitor and possibly an MRA to improve that diuresis and gain better symptom control. I also note that Mrs. Smith was on amlodipine, which might exacerbate peripheral edema, so that could be reviewed as well. So what did we do? So Mrs. Smith's oral diuretics were increased. As a heart failure with preserved ejection fraction patient, SGLT2I was added alongside a diabetic review. There's some emerging evidence that MRA can help support patients with preserved ejection fractions, and so a low dose of spironolactone was added. And ultimately, Mrs. Smith's fluid overload did improve, breathlessness improved, and we were then able to reduce her diuretic dose and monitor that renal function throughout. So second case study, we've now got Mr. Jones, a 78-year-old man with known biventricular impairment, a significantly dilated right heart with severe tricuspid regurgitation and an element of pulmonary hypertension. So Mr. Jones had been on 4 pillars of heart failure treatment, but is now struggling to tolerate these medications. Some of his drugs have had to be reduced due to hypertension and significant postural drops, causing an increased falls risk. Mr. Jones has had significant peripheral edema and has had multiple admissions over the last 12 months, which have involved IV diuresis. His weight is currently 12 kilograms above his previously known dry weight. He's had some really bad shortness of breath. It's been a significant issue, and he's had some episodes of PND, so he's very symptomatic and uncomfortable. On examination, Mr. Jones had pitting edema up to his thigh, had some sacral edema, and chest auscultation revealed crackles in his lower zones on his chest. Blood test showed hyponatremia and deteriorating renal function. So he's currently taking Entresto at a low dose. He's taking, which had dropped from a high dose, bisoprolol 5 milligrams, which had been reduced from 10. Spironolactone, again, the dose had been reduced. He's on dapagliflozin and bumetanide, quite a high dose, 3 milligrams twice a day. So he's still on 4 pillars, but struggling to tolerate those. So we know that Mr. Jones is demonstrating a few hallmarks of approaching end-stage heart failure. So he's had multiple admissions to hospital. He's not tolerating his prognostic medications. He's got a low sodium on his blood tests and recurrent decompensations. We're not really getting on top of his symptom control. So despite that IV diuresis, we're still not achieving stability. So really, it's prudent in these situations to optimize symptom control and quality of life. And we can definitely make some changes which will improve his fluid status. And whilst renal function will probably deteriorate, we need to tolerate this in order to achieve patient comfort. So in this situation, what did we do? So Entresto, bisoprolol and spironolactone was stopped. Subsequently, blood pressure improved and the postural drop improved. We increased diuretics, so bumetanide was increased to 4 milligrams twice a day, and we added in metolazone twice weekly. We saw an improvement in his fluid status, so weight reduced drastically in the first week by 4 kilograms, and then a further 2 kilograms in the second and third weeks were lost. So his weight stabilized at that point. It was above the dry weight, but as we said earlier, we need to understand that certain pathologies we're not going to achieve a dry weight, and ultimately his symptoms improved and he was feeling a lot happier. So that's the most important thing. And so finally, should we ever stop diuretics? So we should always be aiming to achieve symptom control on a minimum dose of diuretics. So if possible, we should reduce the dose, but we only can do that when we know that fluid overload is reduced and symptoms are stable. Ideally, we will achieve a dry weight, depending on the pathology and the patient status. So despite any renal deterioration, diuretics can't be stopped when the patient remains overloaded. We must offload patients. We can't leave them to be short of breath and really struggling to breathe. If renal function is a serious problem and continues to deteriorate, the patient should be under the care of a specialist team, and then they will often liaise with the renal team who will advise how to move forwards and what we can tolerate in terms of renal dysfunction. And then if a patient is in end-stage disease, we can stop prognostic medications in favour of diuretics because they will offer symptom control. So we might gain a little bit extra blood pressure, gain a little bit more renal function, and that will allow us to give the diuretics and gain symptom control. And there's some references.